And so without further ado, patient-centered care, use of opioids in patients with cancer in North Carolina with Dr. Amy Goetzinger. So Dr. Goetzinger, welcome.
Thank you. It's great to be here.
Oh, we really appreciate having you here, and thank you for coming to us remotely today. Let's see, we know that you have a PhD as a licensed psychologist with a specialization in chronic pain, cancer care, and health psychology, and you've served as a faculty member at UNC in the Department of Anesthesiology, Division of Pain Medicine since 2011. Am I on target so far?
You certainly are.
Great. And you work with patients in the outpatient UNC Pain Management Center at UNC Chapel Hill, and also lead inpatient service assessing and treating patients with chronic pain and opioid use disorder at UNC Hillsborough Hospital. And Dr. Goetzinger, individual and collaborative research program, you have this that examines the role of psychosocial, social support, anxiety, depression, and trauma, and behavioral factors in the impact of chronic pain experience and pain coping. And you have consultation and teaching that you do, working, also focusing on safe opioid prescribing, opioid risk screening and assessment, and non-opioid adjunctive therapies for patients with cancer-related pain and other chronic pain concerns. So quite a resume there. What's something that we should know about you, maybe a hobby or other interest that's not on there?
Oh, well, you know, I'm a longtime soccer player, believe it or not. I started playing soccer when I was 5, and I've played my entire life.
Great, great. Good to know. Good for you. Well, I mentioned Poll Everywhere. So our first question, we try to make this first one an easy one just to help you get comfortable using Poll Everywhere. So opioids are the only pain relief methods used with cancer patients. I think that's going to be a pretty easy one. We have a very savvy audience, but if you think that's true, please put A. If you think that's false, put B. And I've got just a little disclosure I need to go over next. This activity has been planned and implemented under the sole supervision of the course directors in association with the UNC Office of Continuing Professional Development. William A. Wood, MD, Masters in Public Health, and CPD staff have no relevant financial relationships with commercial interests as defined by the ACCME. And Amy M. Goetzinger, PhD, has no financial relationships with commercial interests as defined by the ACCME. Whew, done. All right. So we'll take 10, 15 seconds here to allow anyone who has not already responded to that poll to please respond. So go ahead and see what you think. This is anonymous, so we're not going to come back and tell you if you got it wrong. This is just an opportunity to make your best guess on this. Dr. Goetzinger, how are they doing?
They are doing great. 100% have put there are other pain relief strategies and medications to help with pain for cancer patients. This is wonderful. A great start.
Nice. And so without further ado, use of opioids in patients with cancer in North Carolina. And I will, since we have to have the poll everywhere and the slides on the same computer, just let me know when you're ready to advance the slide and I'll move those forward.
Sounds good. Moving forward. So again, I have no disclosures as previously mentioned. First, today's talk is going to be broken into 3 parts, okay? The first part is really understanding factors and the current response about the opioid crisis and how we screen and manage patients who have chronic pain, particularly cancer-related chronic pain. And then the third part of the talk will really go into the heart of what I do as a treatment modality. So we'll look at alternative strategies and therapies for cancer pain, some of which are psychological and behavioral, and some of which are non-opioid analgesic options. So looking at the first part, next slide, we're going to look at factors that contribute to the opioid crisis. And this is really to set the stage and look at what happened to change and affect the guidelines and laws impacting how we look at chronic pain, how we assess chronic pain, and how we treat chronic pain. Next. So to understand cancer-related pain, it's important to understand the overall chronic pain environment. First of all, chronic pain is very prevalent. 20% of individuals in the United States have chronic pain. That's a very large portion. This represents 50 million individuals who have chronic pain, and 8% of the individuals have high impact pain. We're just a few slides later. Number 5. There we go. So you'll look here, 8% have high impact pain, and that really represents severe pain. So if you think about that NRS scale from 0 to 10, with 10 being worst ever pain, that represents scores of 8, 9, or 10. A lot of individuals have severe pain, and we know that pain increases with age. It's more common in women. It's more common for individuals who are disabled. So individuals who stop working, who are on public Medicare or Medicaid assistance, and individuals even in rural communities. So while low back pain is the most common source of pain, followed by diabetic neuropathy, you'll notice the pink sliver there is cancer-related pain. And we'll focus on chronic pain to really understand the environment and the opioid crisis, but then we'll really focus on cancer-related pain and how the guidelines and laws affect us in this area. So moving forward, looking at chronic pain in the opioid crisis, how did we even get here? So we know opioids were first used and first referenced a long time ago. This is around 3400 BC. We first referenced opioids then, but we're not really using them for analgesic purposes all that often until around the 1860s, around the Civil War, when it was used in the battlefield. And then, believe it or not, in 1890, we moved from use primarily of morphine to the development of heroin. So heroin was first developed because we thought that it was less addictive and less abuse potential than morphine. What we learned is this is absolutely not the case. And in 1924, a law was enacted to prohibit the use of heroin, and it was categorized as illicit. Now we look at the 1960s and the 1970s, and during that time period, we see widespread use of illicit substances. But these are substances like marijuana, hallucinogens, cocaine, and this was really more recreational and cultural at the time. But still, it starts to kind of take effect, and individuals are thinking about what we're doing to protect against abuse potential. Now, opioids weren't a frontline medication or substance of abuse around this time, but we start to see things change around 1980, and this is a really key year. In 1980, New England Journal of Medicine published an article. It was actually a commentary, a study of a very small group of patients who were studied in a hospital in the Midwest. So these are patients who experienced post-surgical pain and recovered inpatient in a very controlled environment. And the results of that small study and subsequent commentary that was published was that opioids, when used appropriately to treat pain, have low abuse potential. And really, this article was cited in a number of other studies in the future, including with pharmaceutical companies that started developing opioid derivatives and other medications for chronic pain. This was really a seminal publication. And as you can see, it was not very systematic and not controlled, and it didn't even look at chronic pain. This looked at acute post-surgical pain. So around the 1990s, this is when opioids are kind of gaining steam. There are more opioids being developed and used. And by the mid-1990s, specifically 1995, this is when Purdue Pharma developed OxyContin. And this was the first long-acting opioid medication. So for quite some time, we're working primarily with short-acting medications, and we worry a little bit about the spikes and the drops and whether that is potentially motivating individuals to try to take more of that medication or request more. And we think about long-acting medications. When they were first developed, we thought they were safer that they would lessen the spikes and the drops, and the less frequent dosing would provide better pain relief for longer and minimize abuse and dependence potential. Around the same time, a year later in 1996, this is when the American Pain Society really started pushing pain as something important that we need to assess. So pain became the fifth vital sign and was adopted readily. And then we start to see this push towards heavy marketing of opioids and opioids being prescribed widely. So we get lots and lots of supply and lots of individuals who we know have pain. But then it's not until the late 1990s into the 2000s that we start to see some really serious concerns. We see more addiction, we see more abuse, and we see more overdose. So while opioids were heavily marketed and prescribed, we saw a real influx. And that supply led to this increase in use and also increase in abuse. And some individuals were even using it appropriately, but over time developed physical tolerance and dependence, which are properties that we know exist with these medications. So when we start to see more overdoses around the 2000s, then we start to see the laws and guidelines really become more stringent and tighten up. And this becomes very concerning. The supply of opioids gets drawn in, and other resources become less expensive. So individuals started turning to other things like heroin for pain control, in fact, and it became very concerning. Around 2016, this is when the CDC developed new guidelines for chronic pain and opioid prescribing in general, and then we see a whole host of other things happening thereafter. In 2017, the FDA announced that there's an opioid crisis, and this is a real public health emergency. And in 2017, this is also the start of the STOP Act for North Carolina. So while it's important to understand that around 2010, 2015, there were guidelines coming out about safe opioid prescribing. It wasn't law in North Carolina until 2017. And the STOP Act is actually a series of laws that went into effect sequentially, starting in 2017 and then continually stayed in the CDC guidelines in 2019. So when we think about chronic pain, on the last slide, I had cancer pain inside connected to chronic pain. But here I also want to point out that when we think about cancer pain, this is also something that doesn't quite fit into what we know about chronic pain. While we treat cancer pain very similarly, lots of the same analgesics, lots of the same psychotherapeutic strategies, we also don't necessarily follow all the same laws. So active cancer treatment and treating pain in active cancer patients is not the same as individuals who have chronic pain. Okay, we'll go to next slide. So moving on to understanding how cancer pain really fits into this. One is we know that cancer-related pain is very common. 39% of patients experience pain after curative treatment, and 55% experience pain during treatment. 66%, and I might suggest even more, likely have pain with advanced metastatic or terminal disease. And overall, when we think about that high impact pain, we see 30% with moderate to severe pain. Next slide. So what are the concerns about opioids? We know there's an opioid crisis. We know it's a public health emergency. How do we think about prescribing opioids safely, managing opioids safely? How does it affect patients, and how does it affect providers? We're worried about overdose, and we're worried about abuse or misuse. How do we do this safely? And this is really where pain psychologists come in, both from the work that we do, but also in the education that we provide to others about safe opioid prescribing and management. Next slide. So I mentioned earlier, in 2016, we saw a real change in how we prescribe opioids overall. CDC guidelines were first published in March of 2016. It's important to note that they've actually been updated more recently in 2019. But CDC developed the guidelines in response to concerns about the opioid crisis and specifically about opioid-related deaths. And these guidelines were quite helpful in a number of ways, but they were also difficult to implement and make decisions about. What the guidelines essentially indicated was that for patients who have chronic pain who are prescribed opioids, we need to be very careful about dosing. We need to be very careful about selection of patients and management. And many providers saw this as a real obstacle and a real concern about continuing to prescribe. So many providers in primary care, in other settings, often would say, I can't prescribe to you anymore. And patients were very fearful and left feeling like their pain would be untreated or undertreated, and they would not be able to get medications and treatments that were very helpful for them. So it was a time of significant uncertainty and real fear. Now, it's important when we look at this slide here, the last sentence is really important because CDC guidelines apply specifically to chronic pain in general. And while cancer pain may be a specific type of chronic pain, cancer really is outside of the guidelines. So the guidelines do not apply specifically to patients who have active cancer treatment, who are in palliative care or end-of-life care. The guidelines say specifically we're not applying to them. Moving forward, next slide. When we look at CDC guidelines, there are a couple of really important things. While I just said the caveat that the CDC guidelines specifically don't apply to active cancer treatment, really the guidelines are helpful for understanding how we think of opioids and how we manage patients in all settings. So I would argue while they don't directly apply, they are excellent guidelines to consider and to use. I think we can look at it as they are guidelines that we don't feel compelled to have to follow directly. We can use lots of interpretation and careful consideration, but they're very helpful guidelines to consider. So first, the guidelines look at determining when to initiate and continue opioids for chronic pain. And the important part to remember is that opioids are not a frontline treatment. In chronic pain, there are so many interventions that can help with management of pain. And when we start with opioids, we're basically starting with our big guns, and we're starting with our most dangerous guns. And we want to think about stepping back and starting with things that are safer. When I work with patients who have chronic pain, much of the education that I provide is related to how we think about treating chronic pain. And when I work with cancer patients, it's chronic cancer pain. So we think about treating pain as a very slow and systematic process. We start with things that are much easier to manage with fewer concerns about abuse potential and fewer concerns about side effects. It's important to remember there are a lot of over-the-counter medications that can be helpful, including acetaminophen and NSAIDs, prescription non-steroidal medications, gabapentin and Lyrica and other neuropathic agents, and other SNRIs that are frequently used as adjunctive non-opioid medications. So when we look at patients, it's important to think about the stepwise approach when we start therapies. And opioids really are the last therapy that we look to initiate. Now, when you talk to physicians in the past, if you're in private practice and you're treating a patient, many physicians felt compelled, like patients were coming forward asking for these medications. Someone prescribed opioids to them in the past and they found it beneficial. These were not necessarily patients that were opioid seeking, but they had found it helpful and they were asking for it. So some physicians felt very compelled to prescribe opioids as more of a frontline medication. and there were lots of dangers associated with this. So the guidelines really said, let's stop and hold up. We can't do this. We really need to take some time and exhaust all of our other options first before we start opioids. And then we need to look at opioid selection, dosage, duration, follow-up, and discontinuation. And this is really the management of opioids, and I'll get into that more later. And we also need to assess risk and address harms of opioid use. We need to have the language to use to talk about what may happen when we prescribe these medications, when patients take these medications. And we'll talk about that later as well. So next slide. What happened when CDC guidelines came out initially is there was just a real scare in the field of medicine prescribing these medications. In pain management, providers who were doing this systematically, this didn't make for much of a change, although there was significant concern about dosing of medications and staying under or providing significant rationale for using high-dose regimens. But for many providers, they didn't feel like they had the resources or the tools to be able to do this in a safe manner. And to be perfectly honest, a lot of people felt very scared. And so there was an influx of referrals to pain management clinics, and this caused a real tightening in the pipeline. Lots of patients went without medications, and this was a really, really difficult time. And then we look at a shifting. So next slide. In 2019, CDC guidelines were revised. And here the guidelines said, wait a minute, if you have patients who are on high-dose regimens, and a high-dose regimen by the CDC is termed anything over 90 morphine equivalent units, or MMEs. And what they said was, if there is a rationale for these medications being used safely, using good patient selection and good management and good monitoring, we can do this. We just need to be really thoughtful about the harms and the risks. So really with that pendulum, we found this happy medium somewhere in the middle. And they also said there's a lot of harm to just cutting off these patients abruptly in these really strict tapers, which caused a lot of fear among patients. And just a lot of upheaval in the system. When we looked at what happened in a lot of academic medical centers, a lot of these strategies were already being done for 10 or 15 years. Maybe not the same documentation standards, but a lot of the same management strategies were already being done. So it wasn't altogether new. But in other parts of the country and other parts of North Carolina, particularly even rural areas where there aren't nearly as many pain clinics, this was just incredible time where individuals felt very uncertain, and really a lot of patients were stopped on their medications. The VA specifically, not to take away from the VA, they do excellent work, but the VA took a very strong approach to this and really cut down or cut off all of their patients. And so this was a time where it was, that becomes part of the conversation around opioids, and it induced a lot of fear among many. So the CDC in 2019 comes back and says, we don't need to abruptly stop, we need to be very thoughtful about this. So my talk today is really, how do we take a thoughtful approach to opioids and alternative strategies for analgesia? Next slide. So then again, shifting back to opioids in the cancer setting. In 2018, the National Cancer Institute also published some guidelines related to use of opioids in cancer care. And the nice thing is that this really settled in and was pretty consistent with CDC guidelines. We don't have all the strict rules around prescribing, but it's the same general guidelines. So first, we're supposed to use non-opioid analgesics, consider neuropathic agents, SNRIs, prescription NSAIDs, over-the-counter medications and topical creams, and this really should be a frontline source of analgesia. And then when we think about opioids, if we do start them, it's important to start at low doses and go slow in escalating those doses. Part of the reason we do this is we help understand if there are any harmful effects, but we can also minimize unnecessary dose escalations. And this also asks for proper screening and assessment and selection of patients for opioids, because not all individuals would be seen as appropriate for opioids, even if those individuals had active cancer. And how do we manage those individuals? It gave some good strategies for that, which we'll go into. But we still look at this environment around this time, and this environment around opioids is filled with a lot of fear among patients about having poor pain control. And I talked earlier about the prevalence of pain in cancer. There was considerable pain and considerable dysfunction and quality of life impairment. So a lot of fear around poor pain control, and with that comes poor functioning and poor quality of life. And also fear about these medications. If they'd been taking these medications for pain control, was there increased risk for abuse that they weren't aware of previously? And then patients worried about access. Is my provider still going to prescribe these? Is it going to affect me? Is this going to hit the cancer setting? Is it not? And then providers are compelled to follow these guidelines, some of whom are not trained in these modalities, right? In oncology care, there's lots of training around cancer care and screening, but this is screening for pain. So how do we screen for opioid appropriateness? How do we assess this and monitor patients and appropriately document this in addition to all the regular work that we're doing? And to be perfectly honest, even in the chronic pain setting in general, physicians often in the past felt very, very concerned about doing this. And as a pain psychologist, this was one area that was very helpful to come in, because this is part of what health psychologists and pain psychologists are trained in and specifically do. So not only were we able to come in and do thorough assessments of patients and provide consultation recommendations, but we are also able to educate physicians that we work with, both in pain management, but in other departments and divisions as well, about how to screen for these patients and how to help manage or even co-manage these patients. So also when we look about management, this is next slide, of chronic cancer pain, in 2016, ASCO recommendations came out. So it was the same year as CDC guidelines. And ASCO recommendations looked at asking clinicians to provide or consider needs for cross-disciplinary comprehensive pain management, right? So certainly there are many prescribing providers in oncology that are very able to assess and treat patients' pain, but for patients who have complex needs, when there's significant psychopathology, when there is potentially a history of substance abuse, these are very complex needs. So looking at cross-disciplinary comprehensive management and not taking them on themselves. It also asks for systematically trialing non-opioid analgesics. So again, similar to the CDC guidelines. But it also made sure to point out that when we think about how we treat pain and how we look at analgesia for chronic pain, that we're not just measuring outcomes in terms of pain, but we're looking perhaps even more importantly in terms of functioning and quality of life. How does this impact the whole person? How do they function? We don't want patients on regimens that control pain but leave them asleep throughout the day. We don't want patients on regimens that aren't going to allow them to interact with their families or do the important things that they need to do or want to do. So we also want to maintain other important outcomes, and quality of life and functioning are other very important outcomes. So when we look at how we prescribe these medications and how we even measure outcomes, we're not only looking at pain, we're looking at quality of life and functioning as well, and that was pointed out in these recommendations. And this also asks for consideration of opioids after a careful selection process. So understanding how to screen for risk, which we'll cover later today, and how to monitor for proper adherence. It also asks for that language, understanding the terminology around these specific words around abuse and diversion. So understanding the difference between opioid dependence and physical dependence. With opioids, tolerance and dependence occur naturally from a physiological standpoint, and we have to know that and be able to educate our patients about that. But there's separately abuse, psychological dependence, and addiction, and it's important to have language around these words. When this is not your primary mode of counseling or treatment, that language doesn't need to be terribly sophisticated, but it is important that we understand what they mean and we understand the importance of educating patients, and that can help calm their fears and help them understand how important it is to take their medications as directed and to maintain appropriate management and monitoring. It also helps patients understand when we have them sign a contract around opioid medications that part of this is what they're agreeing to do and part of it is what the provider is agreeing to do. And there has to be a real informed understanding and consent to that process. It's very important. All right, so next slide. I think we're one past. We're to the first poll everywhere question. All right, so here we've covered lots of things about the opioid crisis and opioids in treating cancer-related pain. And the question is, what concerns exist related to opioids in patients who have cancer overall, but in North Carolina specifically?
All right, and so if you think it's NC laws around opioid prescribing for patients with chronic pain have changed, that will be A, and if you're texting in this answer, you would just text in A. B is concurrent use of benzodiazepines. C is patients fear poor pain control and abuse potential, or D, providers must comply with screening assessment, monitoring, and documentation recommendations. Finally, E, all of the above. And if you'll take just another 5 seconds or so to pick what you think is the best answer. Dr. Goetzinger, how are they doing?
They're doing great. The reality is they're all true. So E is the correct response, but all aspects are true. One is North Carolina laws around opioid prescribing have changed. That's the STOP Act that first came out in 2017, but the last round of changes came out in 2020. We do worry about concurrent use of benzodiazepines, and that's because of respiratory suppression and depression and possible accidental overdose. So opioids and concurrent use of benzodiazepines increase that risk, and we don't like patients to be on both unless absolutely necessary. Patients do fear poor pain control and abuse potential, and that we need to really screen and assess and monitor these patients. So all of the above. Great overall.
Thanks so much to all of you for responding. We've got great participation today, over 130 people from all over the state joining us today. So we're so glad you're here.
That's wonderful. Okay, so we're going to shift gears into some of the nuts and bolts about how we actually screen. And I'll talk to you about how I do a thorough assessment, but also how you can take some aspects of this and use it in your own practice, thinking about screening and managing and monitoring these patients as well. So next slide. How do we think about screening and mitigating risk? Next slide. This is a fairly old article that was published in 2009. It's one that I initially was trained off of, and it looks at patient selection and risk stratification. And while it is somewhat old, I wanted to point out that even though we're in 2020, a lot of these strategies have actually been used for quite some time and used quite well. And we might see some changes in practice, but largely a lot of the same recommendations still apply. So when we look at, next slide, screening and monitoring for chronic pain, and this applies to cancer pain as well, it's helpful to know what types of screening tools we can use. And it's helpful to know what that means if we identify someone as either low risk or elevated risk, because some screening tools dichotomize low versus high risk, or if we can stratify them into categories. And oftentimes when we do that, we look at low, moderate, or high risk. And then we look at how we even follow those trajectories over time. It's important to understand we might screen or assess for a patient with chronic pain early in the process, but that this is really a continual process. It's not something we do just once and forget about. It's something that we do initially and then we continue to assess along the way. So even when I do assessments of adherence follow-up for patients, which by the way also are therapeutic appointments. We don't just make it something to assess harm or reduce risk. We also try to teach really positive coping along the way as well. But this is really a continual process of screening and assessment because somebody can change over time and the way we need to manage them may change over time. But we look at some of these recommendations. When someone is considered low risk, we think of them as having fewer risk concerns related to opioid abuse or opioid misuse, okay? And it's important to understand that some individuals might intentionally misuse opioids and other individuals might unintentionally misuse opioids where that was not their original intention, but with poor pain coping or poor pain control, they may find themselves engaging in behaviors that are otherwise not helpful and unsafe. And so education up front while we do screening is really, really important. We need to teach patients why it's important to take their medications like they're supposed to and why we treat pain in a slow and systematic way and we don't just jump and make changes unless there's a significant new pain or something concerning and emergent. So when we look at someone who's low risk, standard guidelines suggest that we have regular urine tox screens. But this typically is every 6 months in our clinic, probably about once a year. So we date and documentation when the urine tox screen is done, and that continues through all of the monitoring notes and then is updated yearly. We also update a pain contract, and I'll show you an example later, once a year, and the patients actually sign that, read through it with a nurse, so they go through, it's an informed consent process. They sign that, and then we upload the signed document. So if someone says later, I never got that, I don't remember, that doesn't make sense, we can say, you did sign that, this is what you signed, let's remind you of how important this is, or take other measures. When someone's considered moderate risk, that means they might have some risk factors, and I'll go into more details about that later. But moderate risk, we really recommend urine tox screen every 6 to 12 months. I'd suggest every 6 months for moderate risk. And you'd also like to see more frequent visits. So for someone low risk, typically those individuals might be seen every 3 months for opioid refills. But in the setting of cancer care, visits might be more often depending on how often they're coming in for cancer-related care. And we also want to look at the opioid dose and the route of administration. So for someone who is moderate to high risk, if we are considering prescribing opioids, we want to consider abuse potential and harm reduction. And so we think about using patches, we think about not allowing PRN medications for acute pain. We think about more frequent follow-up either with the physician or with pain psychology or other individuals who, sometimes mid-level providers, who can monitor adherence more carefully. And we look at that objective data and monitoring in addition to patient report. And all along the way, as I mentioned before, not only are we assessing risk, but we're also assessing pain control, functioning, and quality of life. We want to make sure we're following all of those outcomes so we understand. It's also important to note that with the STOP Act in 2017, the first part of this was having individuals who are prescribing opioids sign up for the North Carolina Controlled Substance Reporting System, or NCSRS. And this is a database that allows all controlled substances that are filled at a pharmacy and prescribed, they're documented here. So review of that at every appointment is important, and we document that in notes as well. Next slide. So I mentioned that we have patients sign a pain contract or pain treatment agreement, and this is really agreement between the provider and the patient. The patient signs this, and it's updated yearly. This states that the patient is going to fill their prescription at one pharmacy for close tracking, and that they receive their prescription from either one clinic or one prescribing provider. It means they keep all of their appointments, they don't no-show, they bring their medications with them for counts at all appointments. So at all of the appointments, patients bring all of their medication in their original bottles to the appointment for pill counts. And it's not something that is purported to be a negative or I don't trust you part of treatment. It becomes part of like, this is how we monitor this safely, and this is how we're allowed to continue prescribing these medications to you. And when we provide that education up front, and not when there's a problem later, there's a much better symbiotic relationship with patient and provider there. So we don't like to see aberrant behaviors, and we put that there up front. We don't like to see medication lost, medication stolen. We do criminal background checks. We have them agree to urine tox screens, including random urine tox screens. It says they won't abuse drugs or alcohol, and that they follow these steps, including the rest of their treatment plan. Because as I mentioned earlier, we're not just looking at opioid medications, but they have to do all of the other things. So you have to do physical therapy. You have to do your exercise recommendations. If weight loss is part of your treatment plan, we'd like you to do that as well. Following up with mental health or pain psychology if that's recommended as well. And then we look at some of the risk behaviors, and these are some of the most common risk behaviors that I'll cover. Looking for individuals who are asking for a preference for short-acting medication. Patients who are coming in saying, I really want some oxy, it's the only thing that helps me. Running out of medications early or unsanctioned dose escalations, calling clinic, asking for medication, obtaining pain medication from another provider, which is a pain contract violation, and borrowing pain medication from others, which is another violation. And then we have more severe ones. So obtaining prescriptions from illicit sources, concurrent abuse of illicit substances, recurrent prescription losses, injecting or inhaling, oral formulations, and forgery. So much more severe aberrant behaviors. And these would be risky behaviors and ones to not prescribe opiates to. And if we do prescribe with some of the less concerning ones with great care and considerable monitoring and adherence follow-up. And when we look at risk factors, the most significant risk factors are personal history of substance abuse, which makes sense, and prior drug or alcohol abuse rehabilitation. That makes sense. It's just a proxy for prior abuse. We also look at aberrant behaviors and criminal activity. In North Carolina, something that I do is look at the North Carolina Department of Corrections database. It's public record. It's something that if you're thinking about starting a patient on opioid medications or any controlled substance, you can look up patient and see if they have any legal history. And it's helpful to do that ahead of time before meeting with the patient so that you have some objective information to corroborate with the patient report. If the patient has a distant history of legal concerns, but they're upfront about it, that's from teenage years, that might be something different than selling or using drugs in more more recent years and concerns related to that. So here are some of the opioid screening tools that might be helpful for your practice. The first is the opioid risk tool on the next slide. The opioid risk tool is a very helpful tool to assess and stratify risk. So individuals can either fill out this form without so you'll see there are actually weighted scores for female and male. This is based on regression models. And so we look at predictive factors that are predictive of future abuse of opioids. So it's different for females and males, but we add this all up, and any individual who scores 0 to 3 would be deemed low risk for future abuse, 4 to 7 is moderate risk for future abuse, and 8+ is high risk for future abuse. And this is one of the most helpful screening tools to use before prescribing opiates. It's also available for public use, and I'll show you later where you can access some of these screening tools. The next one I don't use as often, but it is a popular one that's been around for some time. This is the screener and opioid assessment for patients with pain. It's very appropriate. It is a cutoff for low versus high, and 18 or higher is considered high risk. And then this next tool is very helpful for follow-up adherence measuring. So these are individuals who are currently on opioids and looking at their maintenance and appropriate use of opioids. This is the current opioid misuse measure. It also scores low versus elevated risk, but I think it is very sensitive and is very helpful clinically as a tool. They also has a short form, but I actually like the longer form. So a score of 9 or less is low adherence risk, and 9 or greater is elevated adherence risk. And you'd be amazed because sometimes these are not questions that we always have time to ask during appointments, particularly when we're seeing a number of patients per day. But there's a lot of really helpful clinical information that can come from this. And a lot of times patients will be really honest in filling this out, and it gives you that helpful information to then ask. And we'll go to the next slide. So this here is a really just helpful online databases for Psychometrics. The first is just for some pain management resources, and although it's pain management in general, it's very helpful resources that apply to cancer pain as well. It's through the Substance Abuse and Mental Health Services Administration, or SAMHSA, website. And the second is the Alcohol and Drug Abuse Institute at the University of Washington. They have helpful substance abuse screening and assessment tools for all substance abuse, not just opioids, but you can get lots of those other opioid screening tools there. And then moving to the next slide, when we think about prescribing opioids, it's also important to understand that language about opioids, about that individuals can develop tolerance and dependence as a natural part of taking these medications, but they can also develop something considerably more concerning, which is opioid dependence, which is the definition from ICD-10, termed opioid use disorder in the DSM-5. And when we look at opioid use disorder, it makes sense. These are more concerning substance abuse related concerns. So symptoms of opioid use disorder include using more of a substance and for longer, difficulty controlling or cutting down use, spending lots of time using and lots of time trying to obtain these substances, and experiencing significant cravings. Individuals who are using despite having problems at work, school, or home, and also having problems with important people in their life, family, friends, coworkers. And they're spending less time with functional or important activities and more time using or finding. They're involved in dangerous situations, and they have continued use despite mental health and or health problems. And the last two symptoms, tolerance and withdrawal, are really part of the physical nature of opioids and aren't necessarily indicative of opioid use disorder, but certainly are part of the diagnosis as they go along with it. So on the next slide, we'll look at the opioid contract. And I even, about 10 years ago when I was working in this field and continuing to do adherence follow-up, I termed behavioral adherence plan. So additional term for the extra things that I need patients who are higher risk to do in addition to the standard treatment agreement. And these are strategies to mitigate risk that might include more regular follow-up for adherence, more regular follow-up for mental health. So an individual who might have significant psychopathology, who might have panic, that influences pain, and other psychosocial or mental health concerns, that these are things that we want to make sure we're following up on and treating and monitoring more closely as well. So then we'll kind of move to a nice case example. When we think about risk, how do we apply it to a case, an individual that might be coming in for treatment? So we'll take Tanya here. Tanya is a 56-year-old African-American female with breast cancer. She's had mastectomy and is undergoing chemotherapy. She also has type 2 diabetes. So let's think about where she might be having pain from. It's important to understand that pain doesn't just come from active cancer. It also can come from post-surgical roots, and it can be associated with both chemotherapy and diabetic neuropathy. Now, if Tanya is an individual with minimal mental health history, who is stable, who is not asking for opioids, but experiencing pain, then again, we look at that other medications that are non-opioid first, and getting all of that situated, and then thinking about opioids later. So I use that as a very basic review. And then we'll move on to the next case example. So Charles. Charles is a little older. He's 75. He's a Caucasian male with cancer, status post-surgery and radiation therapy, and he's 6 years in remission. So possible sources of pain could be from surgery, from radiation, and from his prior cancer diagnosis. But what other concerns do we have? Do we have concerns about his age? That's something to consider. What is his quality of life and functioning? Does he have problems with talking or eating or drinking or other aspects of functioning? And we also look at things like, what are his goals for treatment and what are his life goals? It's important to understand at this point he's not an active cancer patient, and so some of the stringent rules around prescribing opioids tighten in this case, but certainly they don't not allow for opioids in this case if that's something that is beneficial for him. And we look at how does it improve quality of life and how does it improve functioning and how do we do that safely. And then in the next slide, I have another example. And this is a patient I saw recently. This is a patient that is high risk. He's 35-year-old Caucasian male, was actually diagnosed with metastatic breast cancer, which was already stage 3 while he was in the military. It took several years for him to be diagnosed. He's been undergoing chemotherapy for 7 years, and thought to have a short life expectancy for quite some time. This individual was actually abusing fentanyl and Dilaudid and diverting. And even in this case, this was an individual that we had considered placing an intrathecal pump for palliative care in order to try to mitigate risk, but help with his pain. And we chose patches specifically. And I'm going to speed up in the interest of time here, okay? So looking at dosing, on the next slide, we can look at some resources that are available for you. The CDC has some really helpful resources looking at where do we start and how do we even change between opioids. On the next slide is an opioid dose calculator. There are lots of options. This is one that I like to use. I think it's very helpful. It's from the website is below. In this first example on the next slide, this is a standard dose of oxycodone, 5 milligrams Q6 hour for a 30 MME equivalent. But on the next slide, you'll see a much higher dose regimen. This is very high, much higher than the 90 MME CDC recommendations of 520 MME. And again, this is palliative. Okay, and I'm going to go quickly through the next couple of slides because these really are just resources from the CDC. So dosing guidelines in the next slide, CDC Resources, app for opioid prescribing, pharmacist resources, helpful notes for tapering, a checklist for prescribing, and non-opioid treatments that are helpful for patients who have pain. And then we'll go to the next question.
Great. So what strategies can we use to mitigate concerns around opioids so that the providers can prescribe and or manage patients with cancer in North Carolina on chronic opioid management? And so A is screening using appropriate screening tools and patient selection. B is monitoring adherence behavior and appropriate documentation. C is using a pain contract with yearly updating. D is following dosing guidelines, start low and go slow. E is use of non-opioid analgesics, and F is all of the above. So take another 5 to 10 seconds, if you would, to select an answer or reselect an answer. If you changed your mind, you have that option too. Dr. Goetzinger, how are they doing?
This is great. This is great. This is another one. So we went over a number of strategies. All of the above are helpful in mitigating concerns and risks related to opioids. And then for the third part of the talk, and in the interest of time, I'm going to skip ahead. So here we're looking at empirically validated coping. It really looks at behavioral therapies, and we'll focus on the second and third wave behavioral therapies. So starting with CBT, but third wave behavioral therapies. And on the next slide, these are a variety of second and third wave behavioral therapies. So main approaches include CBT, ACT, and mindfulness-based strategies, but a number of other helpful strategies exist as well. And on the next slide, this is from the SAMHSA website. Again, this is 12-step programs, CBT, medically assisted treatments like Suboxone and Methadone, which are helpful for opioid use disorder. And on the next slide, we're looking at programs that can be helpful for locating resources. And I'll just review this very quickly. So on the bottom right of the SAMHSA page, this looks at finding buprenorphine providers and also methadone maintenance clinics. You can click on this. On the next slide, it shows you that you can locate in North Carolina. If you put the zip code for patients, you can locate patients who are waivered to prescribe buprenorphine and also methadone maintenance clinics. So this is a great resource if any of your patients have opioid use disorder and you're looking for treatment. On the next slide, another helpful resource is the North Carolina Drug Addiction Resources, the North Carolina Harm Reduction Coalition, and some information there. And the next slide is the Alcohol and Drug Council of North Carolina. Information about suicide prevention if individuals have mental health problems, but also for substance abuse concerns if that is a necessary referral. And then on the next slide, this is really helpful to consider when we look at mental health resources and substance abuse referrals. First of all, I'm a pain psychologist and I'm at UNC, and at the end it shows my email address. So I'm always a potential resource. But if you're trying to refer your patients outside of UNC, if they have Medicaid, we look at the local mental health entities. And if you Google LME or MCO, it gives you a list of the most affordable mental health resources that you can provide for patients. It's really excellent. For patients who have Medicare, it's most helpful to find resources for mental health care via Medicare.gov. And for private insurance, it's helpful to use the Psychology Today database. If you Google any of these, the main page will come up and it'll direct you to how to find some of these resources. Okay, so on the next slide, it just shows you for the local area in North Carolina, Cardinal Innovations and Alliance Behavioral Care are resources for areas. They serve these various counties. And on the next slide are referrals for pain psychology at UNC. Again, That's our main clinic number. You can fax referrals. You can also put a referral in for ambulatory referral for pain psychology. But on the next slide, actually the last slide, it shows my email address. And you can email me questions directly if that's something that is helpful.
Great. And Dr. Goetzinger, let's take that last question. What types of psychotherapy are empirically validated for chronic pain? A, cognitive behavioral therapy, or CBT. B, acceptance and commitment therapy. C, mindfulness-based therapies. D, psychodynamic. E is A, B, and C, or F is all of the above. And I've got a couple of different ideas. We're trending
Yeah.
D and F.
So this one,
how are they doing?
They're doing pretty well. This one's a little tricky because I didn't mention psychodynamic at all. Psychodynamic is rather Freudian, is not considered empirically validated. It's still somewhat used out there. But really when we think about what is skill-based and shown to be helpful by research, it's A, B, and C. So cognitive behavioral therapy, ACT, and mindfulness-based therapies.
Great. And with that, with questions, we'll open up our question poll. So we'll be looking for anyone who does have questions. I know we are running over time a few minutes, but if you do have a question for Dr. Goetzinger, now would be a great time to go ahead and submit that, and I'll be watching for those and posting those. Tell me, while we're waiting for other questions to come in, this process with the contract, I've got to believe if you have a sense that it has been violated, it's easy for a certain amount of subjectivity to creep into that. How do you manage that in terms of, well, you violated it to one extent, but I think we can work around this versus, no, this is just clear cut. The patient has gone too far and there are more significant consequences.
Yeah, I think it's not always clear cut, that there's some room for discussion and understanding. And when we think about managing risk and trying to mitigate it, we also think about working with individuals and making sure they understand, and can we come up with a plan that's safe and viable. So if it's something that's incredibly unsafe and aberrant, that might be grounds for cutting someone off. If it's something that a patient sort of comes clean about and you feel like there's a sense of trust and you can work together, then you can come up with an alternative plan. It's really about mitigating risk. So if we can do that, we really try to do that. But it provides, in some ways, it helps with sort of having some rules for patients to understand, and also having some grounds for providers to feel a level of comfort that patients are going to follow those recommendations and rules.
Thank you so much. And I apologize, a few of these slides aren't. I've got questions for you, but they haven't been popping up on the screen. So let me just read these to you. What is the best way to combat patient fear of opioids during cancer treatment? I feel like the media is making cancer patients afraid of opioids.
Yeah. We get that in chronic pain in general, and I think it's about education. So one, it's important to say that that opioids are not all bad, and we're not shutting down the pipeline for opioids. It's really looking about opioids at understanding risks and making sure patients and providers understand that risk, but that the goal of treatment is to look at functioning and quality of life, and can we do this safely and is effective for the patient. So there is a lot of fear around that, and I think that we can really kind of mitigate those fears by allowing someone to know, if you take these medications the way that we prescribe it, and we continue to meet and monitor this, then we feel safe prescribing it. But this is an ongoing discussion.
Great. Thank you so much. Another comment and question. Great lecture. Even though there are non-opioid pain options, aren't there also negative irreversible side effects, NSAID, heart disease, Tylenol, liver?
Sure, there absolutely are. And when we look at the risks of opioids, we're looking at the risks and side effects of non-opioid analgesics as well. And it's not going to be these medications, you try one and then the next, and they're always going to be appropriate for a patient. I think we have to look at underlying conditions and comorbid conditions and whether it's even appropriate to prescribe something in another class. Most of our patients, many of whom who have other chronic health problems, are on other analgesics, non-opioid analgesics, but some are on many and some are on few. And so, sometimes we look at the creams and gels as less concerning, but we always look at how these medications are metabolized, and we look at the side effects. And just like opioids, if the side effects are too concerning, that's why we start slow with all medications and titrating up. And if there are significant side effects, we stop those medications.
Dr. Goetzinger, thank you so much. This has been tremendously informative. I really want to thank you for taking time from your schedule to meet with us and provide all of this great information. We also want to thank the North Carolina General Assembly for their generous support of the University Cancer Research Fund through the UNC Lineberger Comprehensive Cancer Center. We want to thank Mary King, Veneranda Obore, and John Powell for all the hard work they do for each one of these lectures, including the one today. You know where to find us, unccn@unc.edu or 919-445-1000. Find us on the web, unccn.org, on Facebook, on Twitter. We will continue to bring you lectures even during this pandemic, and we're so appreciative to each and every one of you in the audience for making time from your schedules to be here today. Please pass this on. As I mentioned earlier, this lecture, along with 23 others, are available for you to go and take these lectures as courses online anytime, day or night. We have ASRT, CNE, and ACPE credit for 24 of them, and we've got for 12 of them the CME credit as well. Our next Research to Practice lecture on April 22nd at noon, Head and Neck Cancer Management in North Carolina, updates for 2020 with Dr. Sheth, and then our next Patient-Centered Care lecture, Delivering Survivorship Care in North Carolina with Dr. Mayer. So we hope you'll be here for both of those. We have new courses going online, as I mentioned. Management of Acute Myeloid Leukemia in 2020 with Josh Zeidner is up. Also, Meeting the Needs of Undocumented Patients with Cancer with Julia Rodriguez O'Donnell. Both of those are now available in our portal. All right. Thank you all so much for being here today. Dr. Goetzinger, thank you again. We know this is a difficult time, and we wish each of you and your families and colleagues the very best.
Thank you.
All right. Take care. We'll look forward to seeing you all at our next lecture on the 22nd. Contact us with any questions between now and then. Thank you.